Yeah, we're on. Introduction, Lucas, please.
Hi. Did you check if it's okay on YouTube?
Yes, it's okay.
It's okay.
Did you check if it's okay on YouTube?
Yeah, it's okay.
Yes, it's okay.
Okay. Hi, everybody. Olá, meus amigos. Boa tarde, brasileiros. It's a pleasure to have with us here Dr. Sam Moss from the Medical School of Stanford, United States. Tomás and I will moderate here. We'll start with his lecture, 25 minutes of lecture on preservation rhinoplasty. But first, Sam, can you tell us a bit about you, your history, how you get here today in your life?
Sure. Do you want the long version or the short version? Well, first, I want to thank you very much for having me. It's really an honor, and I feel privileged to have met both of you and your father, of course. Thank you so much. My background is that I was born and raised in the U.S. and did my medical school at Stanford University, and I did my fellowship and my residency in otolaryngology and facial plastic surgery at the University of Washington with Wayne Larrabee and Craig Murakami. I finished that, I'm sorry to say, in 2002, so I've been in practice for 18 years. And one of my big loves is rhinoplasty surgery, and I've tried to take what I learned and add to it every year. And what I'm going to be talking about today is a little bit about what I've added to my toolbox, as it were, in terms of how I approach rhinoplasty. And as you guys know, it's a lifelong process. You never really master it, and that's what makes it so fascinating and interesting to so many of us.
Yes.
Okay.
Perfect, Sam. Thank you for being here again with us. It's a pleasure.
Absolutely.
Yeah, if you want to start your lecture.
Sure. Be
Yeah.
happy to start. Okay, I'm going to hit.
Yeah.
You ready to go?
Ready to go.
Okay,
Yes.
Can you see this okay?
Yes.
Fantastic. So I'm going to take about,
Okay.
let me know if there are any technical issues. I'm going to take about 20 to 25 minutes, something like that, to talk about what I call structural preservation rhinoplasty, in particular a modified subdorsal strip method that I found is very useful, and hopefully share it with you. I don't have any disclosures financially. I'd like to again thank Thomas and Lucas for their hospitality with this. This is the only photo I could find. And Thomas, you're not in it. I think you were getting ready for a big day when I was down there in Florianopolis. But
Yeah, might be.
Your big day. So we went out there. Unfortunately, you weren't there.
Yes.
If anybody has any questions about what we talk about today, you can DM me on Instagram or email me. That's my work email, and I'd be happy to talk to you about it. And a bunch of what we're talking about just came out in a paper that was published in the new JAMA, which is called Facial Plastic Surgery and Aesthetic Medicine. And I'm on the editorial board, one of the associate editors of that journal. And just as another thing, for those of you interested, a book on preservation rhinoplasty is going to be coming out later this year with some of the top people who many of you know. And I'm excited about that, and that'll be coming out later this year in facial plastic surgery clinics. Now, I was trained in the Joseph model for dorsal hump reduction, which is the model of dorsal resection. And the other major school is preservation of the dorsum, which wasn't established by Maurice Caudal. In fact, the preservation model goes back to the late 1800s, but it really fell out of popularity, probably, and Caudal and a few others were the ones who kept it going through the 20th century and the 21st century. But in the last few years, it has been revived as a very popular way to potentially do rhinoplasty. But, you know, as somebody who is not necessarily an early adopter of anything, I like to say I didn't even get the iPhone until the third version came out, even though I live here very close to where Apple is in Silicon Valley. I like to see how things shake out before I jump on board. And I waited a couple of years to see outcome results and things like that from the people who recently adopted preservation techniques. Same thing goes for piezoelectric osteotomies. Once I did that, I dipped my toe in the water and decided to incorporate that into my practice. And the reason I show this slide is because if you only really know how to do one technique or have one tool in your toolbox, everything looks like a nail and you try to do everything with that. And I think that as a rhinoplasty surgeon in your career, you should be skeptical but willing to adopt new techniques as the time goes by, and that will make you a better surgeon and allow you to do better things for your patients. So like I said, the dorsal preservation has been around for over 100 years, and the most popular technique for many years was the Caudal Method. And the osteotomies on the sides are fairly similar in the way they're done, and I'll talk about push down versus let down in a minute, but it's the way the septum is addressed, I think, that varies the most and where some of the interest lies. And this is a schematic of the Caudal Method, which, can you guys see my pointer?
Yep.
Okay, good. So with the Caudal Method, these are the cuts that are done, and this A point comes down to A prime, B comes to B prime, and this whole thing swings downward. And there's this dorsal resection of septum in the subdorsal area, and the whole dorsum comes down. And this is a dissection lab from the Guxel's meeting last year, showing how this works in a cadaver. And I think there's a couple things to notice here. One is that there's tension on this as you pull it down, and this has to be sutured here properly. So a lot of this result's going to depend on that suture stability over time. The other thing I want to point out, there's a little bit of resection here, and if you'll notice, and I know this is just a cadaver specimen, there is a significant step off, and as you pull this forward, it can separate right up there.
Yeah.
So the osteotomies that we use, and this is a cross-section of the nose schematic, and a push-down are that with the Caudal Method, we cut at the bottom of the septum in the front anteriorly, and the whole thing, I should say inferiorly, and the whole thing drops in. And in a letdown, what we're doing instead is actually resecting some of this bone, a varying amount around the sides here, and allowing it to fall into place like so. Now, we recently published a study looking at cross-sectional CTs to look at the airway and how it changes in a push-down versus a letdown, among other things, and showed actually that with the push-down, when you push this bone into this area, you actually narrow this valve. And so I will advocate for using the letdown method instead of a push-down method whenever you can. Saban, good friend Eve, Saban is another person who's been doing a lot of this preservation method and is really, I think, primarily responsible for reviving it, along with Barish Chakir, who's right here. His method is a subdorsal resection, and he does this endonasally. And so with this method, you have some, I think, some better control. You're not relying on the tension of this septal flap being pulled forward and sutured to the nasal spine. And I've done the Caudal Method, and early in my practice in preservation, just over a year ago, I decided, I think, that I wanted to combine things, because I do my rhinoplasties externally, and I do strongly believe in structural rhinoplasty approaches. And so I wanted to come up with a way that I could do a structured approach with dorsal preservation. And so this is what I did. I like to preserve the caudal strut, much like Saban does, because I like doing tongue and groove and other maneuvers to this area to stabilize the nasal tip. So this dorsal strip is preserved, this caudal strip is preserved, and there's a variable amount that's resected in this area. So once this is resected, you can actually determine how much you want to drop this down. One important point is to make flexion cuts in this dorsal segment that allows this to flex down. And Fausto Lopez Ulloa and Jose Montes Brachini have shown, a model where they cut a melon and it falls in, and other people have talked about that, and orange and other things. But basically the idea is you allow this to flex rather than just fall in, and that allows flattening of the dorsum. And you can put more than one cut here. The osteotomy is very key. We like to do this a little bit more transversely than shown here to prevent a step, but a step is one of the things which can happen in about 10 to 15% of the time, in which case you need to put a tiny little graft up there in the radix. When this all flexes down, the open approach allows you to put this suture right through here. You notice how this flexion opened this up. And another suture here, I typically use PDS. And these 2 points, especially this one, allow you to put this into place and not rely on a single suture fixation. The other aspect of this that I really like is, again, this caudal strut is intact, the septum is intact through here, and you can use this for cartilage harvest. And that's what I call this T-strip. Now, obviously, this, you want to maintain this keystone area. I have had it dislodge. It's not the end of the world, but it makes things a little bit more unstable. You can harvest all this or fix septal deviations in this area if you need to, and you can do tongue and groove and all your other structural maneuvers at the same time. So this is what I like to call a structural preservation rhinoplasty approach using the external approach. So this is a schematic showing the same thing. So think of this as a mini caudal in this area, but you can put a dorsal suture here and flex this all down. Yeah. These are cross-sectional images shown, taken from a recent paper, showing at a cross-sectional level right about here in a nose and a dorsal hump. These are where the bony cuts are for a letdown, okay, and the cartilaginous cuts. So for caudal, you actually cut up high and up low. For saban, you cut just subdorsally, and in ours, it's a modified subdorsal cut. And this is what it looks like after it comes down into position. So do you want to stop for questions now, or do you want me to keep going?
I think I think you can keep going.
Okay. Yeah. I'll keep going. So this is a patient who came for dorsal hump reduction. And I love patients like this. She's an attractive young lady who came in, and she has a little deviation of her dorsum, which you see there, but she has a perfect tip and really doesn't want anything messed with that. So this is a very nice opportunity to do a dorsal hump reduction using preservation to preserve the dorsal aesthetic lines and perhaps shift them into a slightly better position. In this case, the modified subdorsal structural approach was used, as shown in this animation. And in cross-section, when you look at it, it looks something like this. So we're going to resect bone here and here, and there's going to be a mid-portion resection right there, and it's going to drop into place. Now, if there's a deviation, you can actually do asymmetric resection of bone. Hers was very mild, so I just simply shifted it slightly to this side when I sutured it in position. Let me go back here. So this is not her, it's a different patient, but it's showing this cut. So very small amount of the upper lat sort of in this bottom portion is just released, just a tiny bit to allow you to get this access. You're preserving the internal valve and this whole complex in this area. This allows you to do tongue and groove and other things like alar spanning sutures to this segment and allows stability of the nasal tip, which I really like. Here, once you cut down, you make a cut in this direction and then resect whatever it is you want to remove. And this is showing this short video showing this piece coming out. Now you can see this has already begun to drop down. Often I've done the osteotomies first, and now this segment is mobile. In fact, you can cut a little bit more cartilage and push it down more, or you can, if you think you took a little too much, suture it back up a little bit higher. So this is the suture going in. This is a 4.0 PDS suture. And then you can also put one up here, which is really hard to show on video or still image, just underneath the flap going through it. I'm going to actually show how you mark that in a video a little bit later. You can see here this drop off. So this is trimmed towards the end of the case. You can actually cut this at an angle, so you get that nice super tip break, and then suture your alar spanning suture to that if you want to use it. This is the same thing from another angle. You see how the dorsum now is dropped down. So this is what we did for this patient. It was fairly straightforward. It's a letdown using piezo osteotomies. There's a flexion cut right here. Single suture in her is all I used, okay? And I sutured it to the right side, and that allowed us to get a little bit straighter because you shifted a little bit to the left. and the tongue and groove. So that was it. This is our intraoperative photo. And I remember her surgery very well because it took just over 1 hour, 50 or 66 minutes. Here she is, her 6-month follow-up. And as I mentioned earlier, I've been doing this for about just over a year now. So some of these follow-ups, in particular with the COVID, you know, I haven't been to the clinic now for 2 months, or a month and a half. So some of these follow-ups are not a year yet. 6-month, 3/4 view, oblique view. Here's frontal view. You can see she's straighter now than she was. And her base view. So one thing that I think is very important in my practice and for all of us is to look at outcomes. And so as many of you know, and some of you may not know, I track everybody's outcomes with the SCHNOS, which is the Standardized Cosmesis Health Nasal Outcomes Survey. And this has been translated into multiple languages. And I like to show now, if I can, if I have the results for all my patients pre and post-operatively, what their scores look like. And so the top 4 here are the breathing questions, and the bottom 6 are the cosmetic questions. And you can see the things that bothered her the most were the straightness of her nose and the shape of her nose from the side. In other words, the profile. She had a little bit of nasal stuffiness. This is what her scores look like after surgery at 6 months. And so I think, you know, rather than just believe me when I tell you she's happy and she's breathing well, you can see the numbers here.
Yeah.
And just a quick plug for this translation into Portuguese that Lucas did, and we're very happy with. So anybody who wants this can get this. What about really crooked noses? So this is a patient with a significant deviation to the left. Typtosis, dorsal hump, wants a profile improved, and as much improvement in the straightness as possible. And if you look at the midline and the glabella and the midline of the Cupid's bow, the nose is really quite off to the patient's left. So using the same method, this structural preservation method with modified subdorsal strip, and combining that with piezo asymmetric osteotomies, now we're going to do asymmetric letdown. Remove this, leave this alone, and we're going to tilt the whole dorsum to the right. And, you know, I've tried many methods and written about different methods for doing this with non-preservation methods like open book osteotomies, spreadografts, and things. And I'll have to say this does work quite well. This is a short video showing this case. So this is showing the asymmetric cuts. Now this is high speed, so my hands are moving really fast here, but I'm marking externally for the purposes of the video what we're going to do. And we measure the dorsum, the distance from the alar facial to the nasal facial groove to the dorsum on both sides, and decide how much to resect. You can see that I've marked about a 3.5 millimeter resection on the patient's right. So using the piezo, we do our osteotomies, and if you're doing an ostectomy for a letdown, it's really important to do the anterior cut first and then the posterior cut, because if you do the posterior cut and then try to do the anterior cut, this is our bony resection here, by the way. If you try to do the anterior cut second, it's a little bit unstable. Okay. And then we do our cartilage portion, and this is showing the same method. Sorry, my hands are a little bit in the way here. This camera is set up above my head. This is showing the cartilage. Now I'm cutting up to the level of the bone. And here it is coming out, small section. And we can determine our flexion point with a needle like this. It's a little bit easier. Sometimes you can fool yourself as to where it is. You're going to do a single flexion point, and then you use a blade to cut upwards. And then an osteotomy at the top to complete release. And notice I'm going to tilt my hand towards the patient's forehead to get the angle. And now we set it into position. And this is our suture going in, our PDS suture, once we're happy with the level, to set the dorsum where we want it. You can see the straightness there. So this is the Gunter diagram for what we did, asymmetric ostectomy to move the dorsum to the right. And the structural approaches here are, I wanted a septal extension graft, so I took some cartilage for that. This is our flexion cut. This is our PDS suture. I put an SEG on the right side also to help straighten her out. So using tongue and groove and SEG, as well as a small morselized cartilage graft in the right tip to improve symmetry. And this is, again, just a schematic cartoon of the way we do it. This is a 4.5 month follow-up. You can see the tip rotation. Here's 3/4 view and the frontal view, which isn't perfectly straight, but it's, I think, much improved. I think probably I could have added some more cartilage here, but again, using a structural approach to preservation, we're able to get a good result. Base view. And of course, the schnoz scores pre and post-operatively, showing an improvement. There's a very slight amount of congestion, but this is really non-significant. So this patient did very well. Another patient. This is a patient with a relatively straight dorsum on frontal view. She did want the dorsum brought down and the tip rotated slightly, as well as deprojected. So in this case, the structural approach included lateral curl overlay of 3 millimeters on each side, as well as our dorsal takedown. I did put a tiny little radix graft in her because I was afraid about a little step off, and that was just a little bit of actually Patangi ligament I put up there. And a tiny bit of morselized cartilage. Again, this is the same method. And here she is. This is about 6 months post-op. She's got a very slight, sorry about this lettering being here. She's got a very slight bump here, but she's very happy. This is her 3/4 view, frontal view, and base view. Sorry, I forgot to mention also alar base. We had very small alar base reductions in her. And this is her pre. Now, she's somebody in whom we're watching. She got a little bit of congestion afterwards. I don't know if it's allergy related, but we're following her. But it's not a major complaint. Her cosmetic scores here in the bottom all went to 0, which is good. And I think this may be the last case before we take questions. This is a patient, again, showing how you can apply structural principles in open preservation rhinoplasty. This patient has a very tonic tip, a very poor tip support. She wants her dorsum taken down, her tip brought up, and some better tip definition. She has some asymmetry of her ala. Alar bases on the left is a little lower than the right. And so using, again, the same split approach. And in this case, resecting a large portion of the septum to do our structural things that we need to do, which included for her mini lateral curl strut grafts, alar spanning sutures, a very small cartilage graft in the super tip, because when I dropped her down, I thought maybe it had gone a little low, wasn't sure. Very minimal cephalic trim, and here's our PDS suturing that we did. So again, using a small cap graft. So I did things that we do in traditional external rhinoplasty, structural approach, but I also used some dorsal preservation principles. And here she is post-op 7 days. I don't usually take pictures at this point. We should have cleaned her nose up a little bit better for that, but you can see there's very minimal bruising, which is great. That doesn't always happen. Here's our frontal view. And then here she is at 4 months, maintaining tip support with our tongue and groove. Excellent dorsum. Here's her 3/4 view, oblique view, frontal view, and base view. These are her preoperative schnoz scores. These are the obstruction scores. These are the cosmetic scores. And you can see she's quite happy and doing quite well postoperatively. We looked at our outcomes in our initial cohort of patients for this with the schnoz, and we basically showed most patients showed improvement in function and significant improvement in cosmesis as well. So we're very happy about that, and we're going to continue to look at that as time goes on and we've done more cases. Just to review, this is kind of the differences. You notice the ostectomies are the same in all of these. It's how the septum is addressed in the Caudal Method, the Saban method, and the method that I've developed. Now, I want to point out that my good friend Carlos Neves and I, about I'd say last June in Turkey, we both had a chat. I actually had a photograph I wanted to show of us on the boat about how we both kind of came up with a very similar approach to the septum, and I know he's talked about this as well, so I want to acknowledge that. but also point out that we independently came up with something which is fairly similar. Again, about the toolbox. I think it's very important if you're a rhinoplasty surgeon, whether you've been in practice as long as I have, or you're new and starting out, that you keep an open mind, but also have a healthy dose of skepticism, particularly when you hear somebody say that something is the only way to do it, the perfect way to do it, that there's no bruising, no complications, or anything like that. That should set off an alarm, because I can tell you that there are problems with every method, and you should carefully dip your toe in the water before you approach new methods, and use your training and your common sense to do the best thing for your patients that you possibly can. And so I think a structural preservation rhinoplasty hybrid approach is the best way for me to approach my patients. I don't do preservation of the dorsum in everybody. I've probably been doing it in about 50% of my patients, but it might go down a little bit as I get more familiar with the method. I think this is a useful tool to have in your toolbox. Think of it as a mini caudal without as much tension at that anterior nasal spine, posterior nasal spine. And it allows for harvest of cartilage and for you to use techniques like SEG, tongue and groove, lateral curl strut grafts, alar spanning sutures, lateral curl overlay. And I have to say, I've done even a few cases with extracorporeal anterior septal reconstruction, which is going to come out in a paper in that issue, in that book on preservation rhinoplasty later this year. So I've been able to incorporate it into most of the methods that I already use in external approach structural rhinoplasty. Again, this is my contact information if anyone has any questions. And of course, we're going to take questions now and discuss for a little while. And I want to thank my hosts very much for having me, and I look forward to our discussion.
Great. Thank you.
Thanks, Sam. Thanks, Sam. Thanks a lot.
So, Sam, there are a lot of questions. We have around 200 people on YouTube watching.
Fantastic. Great.
And one of the questions was the percentage of cases you already answered. And Andres Gantus from Toronto, he's asking, what are the issues with high septal deviations?
Yeah, so high septal deviations are a problem in both the Joseph method and this method. And so in our paper, actually, that we just published, we show a diagram of what are favorable and unfavorable positions for the high dorsal septum. When you do a Joseph approach and you create an open roof, if the dorsal septum is deviated to one side, you can run into problems, particularly if that's the opposite side to the side you want to move the dorsum, or even if it's a straight nose. When you mobilize the bones, the bone will not go in as far on one side as the other when you have that. And so people have talked about using an osteotome or something to release the ethmoid bone, the perpendicular plate, so you could move it over. That's a little bit tricky, I think, and I think with this dorsal preservation approach, you actually can get around that, because when you have that high dorsal septal deviation, you can actually move this. When you do your cut, you actually will be able to move the dorsal segment, this whole piece, to one side or the other, and you can actually suture in position and make sure it's in the right place. As I mentioned in that, I think it was the first case that I showed, she had a very slight deviation to one side. And so I was actually able to position her a little bit to the right when she was deviated left and straighten that out with the suture. I think it's a difficult problem for any dorsal reduction, but in my experience so far, I think it's better to handle it this way than with the external approach, particularly if it's a crooked nose and it's in a, quote, unfavorable position. Is that
okay?
Help?
Okay, Thomas.
Okay.
Thomas, let me share the screen. I have the paper here, so he can.
Oh, yeah. Okay.
Oh, cool.
Yeah, that's it.
Yes, perfect. So
let me just remove Gantu's question.
So here,
yes,
you guys can't see my pointer, can you?
No.
Okay.
No, Lucas pointer.
So on the one on the left, this is an ideal dorsum without any deviation. So The one.
Oops.
Oops, sorry.
Yeah, the neutral,
And-
the neutral.
Yeah, and the one in the middle is considered favorable because that's the way that you want to move the nasal bones. In other words, the nose is slightly deviated to the right, and you want the right nasal bone to mobilize more than the left nasal bone when you do a Joseph method. This is about the Joseph method now. Dorsal hump, this is supposed to be like an open roof. On the opposite side, if the nose is deviated to the right and the septum is also deviated to the right, you're going to have a difficult time because you don't want that left nasal bone to move inwards any more than it has. In fact, you want it to move the opposite way. And so when you do your osteotomies, that right nasal bone is going to want to stay, the left one's going to want to go in, and it may actually make the patient look even more crooked. So you need to do things like double or triple spreader grafts on the left side and try to mobilize that right nasal bone to try to make it look straighter. In this case, dorsal preservation gets around all that. You just drop the whole thing down.
Yeah, cool.
Great.
Another question here from Julia. She's asking when you use piezo or osteotomies to do the osteotomies. Yeah.
So, you know, I use a piezo now in 100% of my preservation rhinoplasties for the lateral and transverse portions. On once in a while, I'll use an osteotome. As you saw, when I used that osteotome, I was just doing the upper transverse osteotomy to release the to mobilize the whole segment. Sometimes I'll do that with the piezotome just under direct visualization as well. I think the advantage of the osteotome is that you can angle it so that you're almost parallel to the forehead and try to get an angled cut so that when it falls in, it sort of slides rather than drop straight down. If you do with the piezo, it's more of a straight cut and you have a chance of it falling in. Now, one of the keys I didn't really talk about in there is originally most people have been talking about resecting a small amount of bone up high or a little bit of that cartilage. I find now it's best to, I just take a Joseph scissor and I cut that ethmoid bone and I try not to resect any so that, because it's very thin often anyway, it just falls in a little bit and doesn't fall in too much. But to answer your question, Julia, I use the piezo for all of these cases and the osteotome once in a while, as I showed in that video, for the transverse at the top.
Cool. Lucas?
No, I'm just saying, I was saying that there was another surgeon that asked the same thing, Irving. The question was, why not do the transverse osteotomy with the piezo? And you already answered. Great.
Yeah, I think that the issue with the piezo is that it cuts all the way through. With the osteotome, you can angle it, and sometimes you can green stick it, which gives you a little bit of flexion rather than a drop.
There is another question here, Ismael.
Okay, this is the dorsal aesthetic lines getting wider.
Yes.
I think that in the super tip, it might widen just a little bit, but that's really been seen with all of the dorsal preservation methods, that there can be a little tiny bit of widening right here. Some people think it opens the valves even just a tiny bit. I can't say that that's necessarily true. So
yeah, we saw this. We saw this
a little bit. Sorry.
We saw this in your study, in your article.
Yeah. And the other issue is
I can share Thomas.
Yeah, you can share the article.
Yes.
Yes.
Perfect.
Você tem aí, Lucas?
Yes.
He's opening your article about the aeronasal valve area. Yeah. Because it was a question that was always in my mind about that bone that you throw it medially, and what happens? You can get some obstruction, and here's your
and just to point out, this Caio Neves is Brazilian. He helped us greatly with this study. So the interesting part about this was I wasn't necessarily expecting to see narrowing at the upper valve area. I was expecting maybe more to see that the bones themselves were obstructing by coming into the airway when you push them in. But we did find that that angle does narrow slightly. And the other aspect of the study, which we didn't talk about, which I didn't talk about earlier, is that, these are cadaver specimens, so it's not real patients, but the using structural methods with the Joseph technique to repair the valve results in a pretty similar result. So the dorsal preservation isn't necessarily superior to a well-done Joseph technique whereby you do the valve repair. Okay, so I think that's another important aspect of this to consider, is that when proponents of preservation rhinoplasty say it's superior without any evidence, that's not necessarily the case if you do a good job with the other method. So I think that's an important aspect of the study. And the other aspect of it was that, after doing this, I really don't like doing push downs. I also think with a push down, there's a tendency for it to want to come back up because the nasal bones are squeezed in.
Recurrence. Yes.
So I think you might as well just resect, even if it's a small amount of bone, because it's a very small hump. Just resect a small amount and not have to worry about that aspect.
And Sam, what do you think you would get if you make the same study and using spreader graphs?
Probably, you mean when I do the Joseph method, I think probably it would be just as good as the auto spreaders.
The auto spreaders.
Yeah.
Yeah. Okay.
I'm just guessing.
Yeah.
I really hate saying things without data. I know a lot of my
we all can
get excited and just talk about, well, this is the best. I really don't like doing that. I like if I'm going to say something, I try to at least have something to back it up. But that's hard to do, and it takes time to generate data.
Yeah. And Sam, there's a question here from Marco, my friend Marco. He's asking how often you have the dorsal hump recurrence.
So my N is about 50 or 60 so far, only in the past year, and I've not revised any dorsums. But you did see in that patient, she had a very small bump. Yeah. But I have to say, that happens to me sometimes with the Joseph technique. So I mean, I'd have to do, and we are doing a cohort comparison study once we have longer term follow-up on these preservation cases, to look at what revision rates are. And I think the important question isn't so much what is the recurrence of the dorsal hump with this method, is what is it compared to what your results are with the other best method that you use, which is the Joseph method.
Yeah. And what do you think about it in your hands?
Oh, me?
Yeah.
Are you asking me? Yeah. Well, so I think the rate's going to. Boy, I'm afraid to say something. I'd say probably 5 or 6%. I don't know. I know I have a couple of people that afterwards their dorsum look like, it's a little bit still there, but I don't know if that's because it actually recurred or if that's because I was fooled in the operating room. I don't know that it actually came up, which is really the question. And the same thing happens with dorsal hump reduction with the Joseph method. It looks perfect in the operating room, just the way you want it. And then in 6 months, you look and there's a little tiny irregularity.
Yeah.
So it's really hard to know. I think a lot of it has to do with the way patients heal, their skin thickness and swelling in the operating room, and how things go in the postoperative period. So I think that particularly with that suture that we place right over the cartilaginous dorsum at the rhinion and suture it down with 4O PDS, as well as the suture caudally, the likelihood that it's going to actually pop up is low. The question is really, did you put the dorsum really where it should be based on their skin thickness and swelling, and did you make the right judgment? But that's a really tough one because everybody's skin is different.
Yeah.
Tomás, you skipped the Geraldo question.
Another question here, Geraldo. Do you think it's possible to use this sort of approach when you have an S-shaped dorsum? Yep.
So what you're referring to is this nomenclature that's popped out, which I'm not super big fan of, but just so everybody understands what the question is if patients have a very kyphotic hump, in other words, it's very deep radix and a very sort of prominent hump versus a more V-shaped hump, less V-shaped, a flatter hump, more gentle curve. Which one's better, and can you do this? I think that one of the things about dorsal preservation, whichever method you use, is you have to be careful when the patient has a deep radix and a very kyphotic hump. And that's something that other people have spoken about. So by S-shaped, if you mean this patient has a very kyphotic hump, then I think you have to be careful. I prefer that nomenclature because I think people get things mixed up, V-shape, S-shape, and they don't really understand exactly what's going on. But I think there are patients who tend to be more ideal and patients who tend to not be. And certainly a low radix with a high hump or a medium, flat radix with a really high hump is a difficult one because you're concerned about dropping this in too far.
Yeah.
Yeah, there was another question about this V shape and S shape, and you answered it. Great.
Yeah. Andre. Another one, Lucas?
Yes. Irene is asking about spreader graft.
Yeah.
Okay, so if you need a spreader graft, yes. That's one of the really nice things about this method, and I have a few cases where we did put very small spreader grafts right in that supertip area. You're able to do all the things you do in structural rhinoplasty with this method. So if you want to put a unilateral spreader graft, you can do that. You have that caudal segment of septum which is intact. I think I have this diagram up right here behind me. So you have this, you have this caudal segment of septum which is intact, and you can place it on one side or the other if you wish.
No.
So I can put the slide back up if you want, but
okay.
it would be a submucopericondrial pocket if you did that. Yeah.
Yeah. Okay.
And before Irene,
yes.
there is Giovanni.
Giovanni is asking about.
If you do something to the upper lats.
Yep.
Yeah. So I didn't explain this. I think let me say something first, and maybe it'll answer this question. When performing this, maybe I can. No, I can't go. Let's see here.
Well, let's see if your lecture is here. No, it's your computer. It's your desktop.
There we go. Can you see this?
Yes.
Okay.
Yes.
So I actually release this this piriform ligament along the side here, and this is something that a number of people have described. So I don't think any one person. What happens is when you do that, it allows this to separate. I know Guxel likes to call it the Ballerina Maneuver. I think that Milos told him that. I don't know, but a lot of people have done that. And when you cut along this, releasing this piriform ligament, it allows the whole thing to flex. Because you imagine you want this to flex right here, and by cutting here, you allow this to separate just a little bit. I don't resect the upper laterals otherwise, if that was the question. And the other part of it is the increase in the middle third a problem for you? I think this relates back perhaps to the question that was posed earlier about the widening. And I think that there's a small amount of widening right in the super-tip in these patients sometimes. And I don't think it's a problem.
It's a problem, okay.
Okay, so Paulo is asking, how do you calculate the amount of reduction?
So I would say be conservative. So if you think you need just a couple of 3 or 4 millimeters of reduction, take 2, see how it looks, and you can always take a little bit more. The problem you get into is if you over resect and then you've gone too low, then you potentially have a problem. And I think really the biggest issue is destabilizing the ethmoid, the perpendicular plate of ethmoid up at the level of the radix, and it falls in too far. So that's why, one of the things that I noticed early on was we were, the way we were doing it was taking a through biter and cutting out some bone up there or some cartilage and allowing it to fall in, but you don't really need to do that. You can just cut it if it's very thin. If the bone is thick and you find that when you do it and it pops down, it wants to fall to one side or the other, then you can resect just a little bit to allow it to fall in. But the subdorsal resection of the cartilage is, I'd say, take 75% of what you think you need, see how it looks, and then take a little bit more.
Same thing in the regular rhinoplasty, you know. Same thing. Yeah. Same thing you do in the.
Yeah, absolutely.
There's a question that relates to this. Mateus, he's asking, how do you plan the amount of dorsal reduction on the preoperative evaluation? How do you plan it?
Well, there are two factors. One is, the bony resection, and the next is, on the lateral osteotomies, on the letdown, and the other aspect is the subdorsal resection. The lateral osteotomies, those I do just the amount that I want. I don't underestimate. I say I'm just going to take 2 to 3 to 4 millimeters. Typically, it's about 3. And if there's an asymmetry that I want to correct, I will actually put a dotted line down the middle of the dorsum and measure the distance from the nasal facial groove on both sides and decide how much I need to do to even them out. And I showed a case like that during this lecture. In terms of the subdorsal resection, it is what I said, about 75%. I don't measure on the photographs. Maybe I should, but I actually kind of do it by eye in the operating room. But yeah, I do have the preoperative and postoperative photographs with me, and I have them on a big computer screen. In fact, I do a digital subtraction image so I can see exactly how much I want to remove. But I don't measure it to the millimeter and then do that corresponding resection in the operating room.
Okay. Dr. Renato is asking here, Sam, how do you deal with the low radix? I think the last case that you show,
she was kind of low.
Just kind of low radix.
A little bit, yeah. I was a little bit concerned about her because she had a relatively low radix and she wanted this. And so she wasn't one of the first cases that I'd done. I'd done about 40 or 50 cases before I got to her case. And the key there is to be very diligent and careful when you do the osteotomy high up and don't resect any bone so it doesn't drop down too far. You want it to primarily flex in this direction and not just fall in. And I think in that patient, I ended up, when I brought her down, I thought actually I needed to put a tiny graft right here because maybe there was too much of a super tip break. Yeah. And it looks good post-op, but it's a judgment issue. Now, she did not have a very kyphotic hump. So if she had a really prominent hump and a low radix, I probably would not have done this approach.
Okay. And if you need to use a graft in the radix, a radix graft, what do you use? Do you prefer to use? I
don't like to use cartilage. In one of those cases, I think I did put a tiny bit. If I put cartilage up there, it is really morselized to almost just a paste. I don't like, because it can become very palpable later. But I'll often use just a little bit of fascia. I like to use a little bit of Patengi ligament. If I take that out, I don't preserve that. I know people are talking about that now. But I like to put that up there. And so I think that something very soft is the key.
Okay.
Agree.
Yeah, agree. Dr. Caro Preso is asking about the modified Joseph method. Yep.
Do you mean the modified caudal or the? I asking about this method, upper septal deviation. So yeah, so this is kind of similar, I think, to Dr. Gantu's question. I think that depending on the, when you examine the patient, where the septal deviation is and how deviated they are, I really like using this method for these patients because of the ability to actually resect the bone and put it in a position. Now, one thing I like to point out is that one of the major differences between the Joseph method and this method is, they're both very destructive. Both of them involve a lot of osteotomies and mobilization. But when you cut the nasal bones on the dorsum, where the skin is relatively thin and the shadows are very visible, it's much more difficult to hide any irregularities. So in a crooked nose, this is very difficult. When you're cutting in this underneath this very thick skin of the nasofacial groove, you're doing your osteotomies primarily out there, and you can resect and shift things into position, and the bone will heal. I think you're in an advantage because you're hiding a lot of those cuts. So that's just a general philosophical thing about this sort of preservation rhinoplasty versus dorsal approaches.
Okay, Lucas?
Elena is asking if it's safe to rasp the dorsal if you need.
Yeah, I think people talk about that, and sometimes, some people even talk about taking down the bony cap and just doing a cartilaginous letdown, and there's papers out there about that. So there's so many variations, and there's more than one way. I certainly think, particularly with the piezo, because it's so gentle, if you do this dorsal thing and the preservation, and you feel like there's just a little bit of bone or a little bit of an asymmetry of the bones, you can very nicely and very gently shave it. And one thing that the piezotome allows you to do is work on a mobile segment of bone because it's very gentle. Rasp would be very difficult to do on that once it's been mobilized. But yes, it's true. And one thing that I want to point out historically is that I'm very lucky to actually have one of Maurice Caudal's original course manuals from 1957 in my office with 12 cases that he did with operative notes and photographs preoperatively with measurements on them. 4 of those cases were what we call now dorsal preservation. He didn't call it at that time. And in all 4 of them, he did dorsal rasping. So he was routinely rasping the dorsum as well as cutting from the sides to drop it in to get that final shape. Unfortunately, I have no post-ops on any of those patients, but I do have their pictures from pre-op and the description of what Caudal did in the surgery.
Interesting, very interesting. Let's go for some more questions.
Yeah, Eduardo.
Yes, thank you. So my approach to functional rhinoplasty using the complete transverse osteotomy. So, when I do functional rhinoplasty, I don't necessarily always do preservation. So if somebody needs internal valve opening and they really need a spreader graft, I will just go ahead and do that. Patients who need a dorsal hump reduction and have a septal deviation or severe septal deviation or a minor valve narrowing on one side, I will go ahead and do dorsal preservation. The transverse osteotomy, I think, doesn't really make a big difference as long as you are structurally sound at the end of the case. And no matter whether you're doing aesthetic surgery or functional surgery, you need to make sure that everything is stable. If that answers the question.
Yeah. His other question was about the extracorporeal septoplasty and how do you do that? Do you want to explain something? I have a picture.
Yeah, actually, I was debating whether I should show those slides in this talk, where I ended up taking 25 minutes, so I didn't want to put anything in there. But I mentioned it. We've done a few cases. We've done a few cases where we've done extracorporeal what I call anterior septal reconstruction, and we've done a few papers on that. And we've done dorsal preservation, and it's kind of scary. So I will tell you that you've basically taken out the septum, and then this whole thing is mobile. There's nothing underneath it. So that's something that I've done a few times and I'm getting pretty comfortable with. But you really need to make sure that you're comfortable with both of those before you do it. Now, when you do that, I place spreader grafts along that dorsal segment, and then I place the anterior septal reconstruction graft in position on the nasal spine, and then you suture the spreader grafts to that at the height that you want. So if you think about it, there's a lot of potential for problems. You have to make sure that you have a good segment of cartilage to use for grafting, because you need 2 spreader grafts and an anterior septal reconstruction graft. But I have done some of those cases, and actually we're going to describe that in one of the papers that comes out in that that preservation rhinoplasty book later this year.
Cool. Lucas is gone. Yeah, he'll come back. There's another question here, Sam. about your post-op dressing. How do you do this?
So typically post-operatively, the patients have tape and a thermoplastic splint, which stays for 1 week. I don't tape any longer than that. If we've done any major septal work, then we'll put Doyle splints in, which have vents, which are very strong. Excuse me. But if not, what I like to use are very soft silastic sheets, 0.51 millimeters, very soft, doesn't really bother the patient as much as Doyle splints do, and they're very easy to remove. And we roll them and gently put them in each nostril and suture them in position. In some cases, which is pretty rare, I don't use anything, just a mattress suture through the septum. But I do like using something to compress that dead space on the septum.
Cool. We have Fausto here.
Oh,
Fausto. Hi, Fausto. Yeah.
Okay. Yeah. So Fausto is one of the people who taught me about this for many years, just so everybody knows, and of course is well known for that. And he's actually writing one of the chapters in this book that's going to come out. So Fausto was asking what percent. So that's the thing. So I do primarily external approach rhinoplasty. So 95%. You know, the 5% that I do endonasally are patients who maybe just need osteotomies or just a little minor revision or something. So for me, that's kind of the way I do things. But of course, you can do, as you do, Fausto, most of these endonasally. And that's the way it was originally described by Caudal and of course your father and yourself. So there are different ways of doing it. Now, doing all the structural stuff that I do, I think would be, and using the piezo and all that stuff might be a little bit harder with an endonasal approach. But I think that just like I mentioned earlier, you have to, when you're a rhinoplasty surgeon, you initially start out with what you're trained with and you add things to what you do over time, and whatever gives you the best results for your patients.
Yeah. Well, let's go a few questions. Dr. Alessandro is asking you, Sam.
Tony Stark.
Our Iron Man.
Okay, do you use several fractures in the nasal bone if it's very convex using piezo? Yeah, so this is not necessarily related to preservation or dorsal preservation rhinoplasty, but yes, using the piezo you can do multiple osteotomies, particularly in crooked noses, to shift the nasal bones around. I think that it is incorrect, as was initially espoused by the people who started using piezo, that it was impossible to get flail segments and these patients had no bruising. That's just absolutely not the case. You can get flail segments with the piezo. You have to be careful, just like you are with regular osteotomies. I think it's more gentle, so you're less likely to. And I think you can actually do more finesse with the piezo. But yes, transverse, intermediate osteotomies, all that kind of stuff you can do with the piezo.
Yeah. Cool. Lucas?
Yeah, the next question is about the tongue groove.
What's the stiffness?
And Tomas, I can share the screen of his paper on tongue groove, so he can Sam can tell us better about that.
Yeah, so the original description of tongue and groove, or at least the first one that I'm aware of, was Kreidel and Hossam Foda, and it showed 3 sutures, holding the whole thing in place, and I think that can result in a lot of stiffness. We've recently published a couple of papers, including a video describing the relationship between rotation, projection, and stiffness, depending on where you place the suture. And it's absolutely true that you can create, there you go, thank you, that you can create a lot of stiffness, particularly if the suture is close to the nasal tip. The suture can be placed very low where the foot plates already overlap. So if you don't want to have any rotation and any retraction at all of your septum, and you don't want to add a septal extension graft, by placing the suture very low, you will maintain the normal flexion of the upper portion of the medial crura and the tip cartilages. The other things that lead to stiffness are alar spanning sutures and things like that, so you have to separate that out. I do tongue and groove in 99% of my rhinoplasties. without any big complaints at all about noses being overly stiff.
Yeah, I use it a lot also.
And using this method, I have much more long-term control, which is, I think, the key. Long-term control of tip position, rotation, projection, and what have you. So I think that there's a lot of, some people, they put a suture up high and they over-rotate, shorten the nose, or even if they don't do that, it's very stiff because they did that. I think that's an issue. If you put an SEG in place and put the tip on top of that, then you're going to have more stiffness regardless of the tongue and groove.
Yes.
So I think there are a lot of other issues. It's not just the suture.
You
agree with that, Thomas?
What kind of suture do you use?
I've used PDS suture, but I prefer to use a 5-0 Prolene now. I use primarily.
Okay, yeah. I'm using an observable suture also.
Mm-hmm.
Okay.
I prefer.
Mario is asking about if you think you're going to do more preservation or less in the next years.
I think that as we, hi Mario, it's good to hear from you. So I think that just like any technique, we're going to learn more as more people do it and more people write about it and have experience with it, about what the right cases are to do and what the wrong cases are to do. I think in the first 6 months or so, I was doing something like 70% of my dorsal reductions with preservation. And I think that number is going to come down a little bit. Maybe it'll end up being 50-50 or 60-40 or something. There are definitely some things I really like about dorsal preservation. I really like the dorsal aesthetic lines. I like now what I can do with crooked noses. I think that to answer your question, I'll probably do a little bit less than I did the first 6 months, but it's going to be a significant part of my practice going forward.
Yeah. Okay, Lucas.
Yeah, Geraldo is asking again if, for example, we have a settle on the post-op. What's your suggestion for correction? And what are what do you do for settle correction?
So fortunately, that is a big concern. So fortunately, I've not had any saddles. I did, like I said, in the one patient, on the operating table, I thought just the super tip was a little bit low, so I put a little tiny graft there, but it was not a big deal. I wouldn't call it a saddle at all. That's a patient that I showed you. One of the keys, I think, is not over resecting initially that caudal strip, and if you just take out a conservative amount and suture down in C, you will prevent a saddle from occurring. I think that the caudal method is a little bit riskier because everything is dependent on that suture that you pull down and suture to the nasal spine, and that makes me nervous. If that slips or falls to the side, the tip support, everything goes with it, and so that's why I like doing it the way that I do it.
Good, perfect. Well, we'll have 5 more minutes.
Yeah,
let's see.
We have a 3 or 4 questions.
A lot of questions here, Sam.
Yeah,
good.
Yeah, Klaus is asking if you have any indication for low strip.
By low strip, are we talking? I'm not sure I understand what a low strip. The high strip. So a high strip is sort of what Saban is doing. At least that's what in my mind. And I think of what we're doing is sort of a mid-level strip or a subdorsal, a little bit mid-subdorsal. A low strip, I guess, would be along the vomer. Is that a low strip? I'm not sure. That's sort of the caudal method. Is that what you guys? How do you guys interpret the question?
Yeah, I interpret like that because there's another question. Sergio is asking, why do you not do the classic caudal? It's been done for a lot of years now, and there are people that have good results. Why did you change?
Yeah, so I don't mean to say that people can't get good results with that, and I don't mean to say that any one method is better than others. The key is what is working for you, and based on all the things I do, like a tongue and groove suture onto that caudal segment. If I do the caudal method with external approach and I suture to the nasal spine, and that moves any way, right, left, or moves backwards, it will destroy everything else that I'm doing. I need that segment to be absolutely solid. And so for me, the first few cases that I did the Caudal Method, and I wasn't seeing the stability that I like to see because there's tension for it to rotate posteriorly. You're depending on that for the dorsal profile, and on top of that, for my methods, you're depending on that for your tongue and groove, alar spanning suture, everything else. So I decided to get around that by preserving that caudal, the CAUDAL segment, and then doing this modified subdorsal resection. People will get great results. I don't doubt that other people get great results with it. It's been around 60, 70 years, the Caudal Method. So I'm not saying that whatsoever, but what works for me is the way that I'm doing it.
Cool. Perfect.
Julia is asking, when you repeat the questionnaire with 1 month, 3 months, or 6 months, what's your routine?
Yeah, so they get it preoperatively, and then we give it to them again. The first time we give it to them again is at 1 month, and 3 months, 6 months, and a year, or whenever they come in. And most of we're going to be, actually, it's a paper that's hopefully going to be accepted very shortly in laryngoscope. It's in its revision. We want to look at how long it takes for those numbers to become stable, because we're all taught it takes a year. So we're going to hopefully be able to show where that number stabilizes for both cosmetic and functional aspects.
Cool. When it is?
Usually by 3 or 4 months, it's pretty stable.
Yeah.
I'm not saying the nose might not change shape, but they're already about as happy as they're going to be usually. But sometimes the tip takes longer, but it'll be interesting to see. We already did that paper with the nose questionnaire. We published it in Facial Plastic Surgery, I think in 2017 or 2016, for functional aspects. And at 3 months, it's as good as it is at a year. So we know the breathing part is pretty stable at 3 months. It's the cosmetic part.
Okay, Thomas, can you share my screen here so I can show the questionnaire? Okay, for the Brazilians, we just published the validation of the questionnaire. It's in the last edition of the Facial Plastic Surgery and Aesthetic Medicine, former JAMA Facial Plastic. And the questionnaire is here on the second page. Here are the 10 questions. So I strongly suggest all our friends in Brazil and Portugal to use to all your cases. So if you want to publish something someday, you have the data, as has showed us.
And, I have to say that, even if you don't want to publish, it's nice to know before you walk into the patient's room, whether they're there, have a breathing problem or a cosmetic problem, and what it is, before you walk in the room for a consultation. And when you see them post-operatively, your assistant hands you the chart and you look at the questionnaire and you can already tell if it's worked or if there's a problem, and it's just a great thing. So I think it's great for research. That's one of the primary purposes, but it's also part of a standard way of making sure your practice is going well and seeing how you're doing with your patients.
Yes. Perfect. I think that's it.
Okay. Yeah, that's it, Sam. I want to thank you. I want to thank you for your time. It was amazing. Thank you very much. Your lecture and our considerations, answering the questions. Perfect. Thank you very much. Thank you all guys watching us from all around the world. We are almost 200 people here discussing rhinoplasty. It was fantastic. Thank you, Sam.
Thank you so much, guys, for hosting it, and I look forward to seeing you again in person when all this is over. Thank you for doing it.
Yes.
Be careful, stay safe.
And happy Easter to everyone.
Happy Easter.
Happy Easter to everybody. Yeah.
Bye,
Thank
Sam.
you very much, Sam. Thank you very much.
Bye. Thank you.
Bye. Thank you. Bye. Acabou.